I'm Amy Regan from FullScript, and I'm so glad that you joined us today. A few housekeeping notes. Please place all questions you have in the Q&A box for a chance for them to be answered at the end of the presentation. This webinar is being recorded, and the recording will be sent via email to all attendees and registrants, as well as available to watch in a few days at fullscript.com/webinars. There is a copy of the presentation slides for you to download. How's everything looking? Excellent, excellent. Thanks so much for joining, everyone. It is so my pleasure to introduce and welcome today's speaker. Maureen Pickle is an experienced NCCPA certified physician assistant that combines conventional medical training with nutritional and functional medicine. She holds a Bachelor of Science from the Michigan State University, a Master of Public Health degree from the University of Michigan, and a physician assistant degree, along with over 20 years of clinical experience. Maureen specializes in preventative, comprehensive women's health care throughout all life stages. We're so glad that you're here, Maureen. Welcome.
Thank you so much for the invitation and the introduction, Amy. As Amy stated, my name is Pickle, and I will be presenting on the female microbiome today, and more specifically, practical applications for optimizing women's health. So a brief disclosure, I work as a clinical science liaison for Novonesis and a BiomeFX consultant for Microbiome Labs. And the information presented in today's presentation is for educational and informational purposes only, not intended to provide medical advice, diagnosis, or treatment. I hope we all walk away from today's conversation with a better understanding and a brief overview of the importance of a healthy versus the dysbiotic vagina, along with the healthy versus the dysbiotic bladder and urinary tract. We'll review conventional treatments for bacterial vaginosis and candida infections, but most importantly, we'll review the bacterial strains associated with an optimal vaginal microbiome. It only takes one mammogram, one breast biopsy, one colposcopy, or one grandmother with recurrent urinary tract infections to know there are significant gaps in women's health research and innovation, many of which stem from inadequate funding and lack of representation in clinical studies. These gaps have led to disparity in the diagnosis, treatment, and understanding of women's unique health needs. Historically, clinical trials have favored male participants, often under the assumption that results would be applicable to both men and women. But this has led to gaps in understanding how treatments and medical devices specifically affect women. This lack of gender-specific research has resulted in a lack of understanding about women's unique biological processes, such as hormonal fluctuations, pregnancy, and menopause, which are too often overlooked in clinical research. This can result in treatments that are less effective or even harmful to women. We've seen this clearly with recent updates in cardiovascular health, which we'll be talking about at Microbiome Labs in February. It wasn't until 1993, just over 30 years ago, that the US Congress passed the NIH Revitalization Act, requiring the inclusion of women in clinical research. Yet, a Harvard Medical School study found as recent as 2019, women were still substantially underrepresented in clinical trials for leading diseases. According to the well-known global management consulting firm McKinsey & Company, only 1% of healthcare research and innovation was invested in female-specific conditions beyond oncology. And this is particularly troubling to someone like myself with a background in public health. I read in Nature's Review Bioengineering that viewing women's health as a comprehensive and essential part of healthcare will drive better policies, more research, and greater investment to benefit society as a whole. And I personally believe that when we support the well-being of women, we are removing barriers to their ability to live to their potential, and we acknowledge that healthier women create healthier communities. The takeaway is that we are all an essential part of this healthcare that will optimize women's health. And for that reason, I'm happy you joined us today. The vaginal microbiome is a community of organisms, including bacteria, that live in the vagina. Vaginal health is a crucial component of women's overall well-being. Maintaining this healthy ecosystem intended to protect us from infections, the vaginal tissue functions as a dynamic ecosystem and is influenced by things like the diet. High vitamin C, vitamin A, vitamin E are all associated with decreased bacterial vaginosis, whereas a high glycemic load and high fat diets are also linked to a higher incidence of bacterial vaginosis. And we know flavonoids protect the urinary system from infections. It's no surprise that hormonal factors and hormonal changes play an important role, and we'll talk about that in just a moment. Sexual activity and the lubricants that are inserted in the vagina are an important factor. Glycerin and lubricants and coconut oil can be destructive to the microbiome. There are companies like Good Clean Energy that make lubricants without glycerin, and we now have research published in Cell Host and Microbe showing that oleic acid in organic olive oil is found to be beneficial to the microbiome. This is particularly fascinating when you consider the frequent use of glycerin lubricants used during gynecologic and fertility exams. Genetics appear to be a factor in some of the health disparities we see amongst racial groups. And hygiene practices, as recently highlighted by the work of Dr. Sarah Labier from the University of Antwerp, highlighted the importance of cotton versus synthetic fabrics next to the vagina. Research found that the use of tampons was associated with dysbiosis, and menstrual cup use was associated with a more beneficial environment. We're not surprised to know environmental toxins like tobacco can be dangerous to the microbiome, as well as medications like antibiotics. And perceived stress and elevated cortisol can affect the vaginal pH. Many of you may be familiar with the groundbreaking work of Dr. Jacques Ravel. Dr. Ravel is a professor of microbiology and immunology at the University of Maryland. And in 2011, his team identified 5 patterns in the vaginal microbial community after studying nearly a 400 asymptomatic cohort of reproductive age women in a longitudinal study. 4 groups were dominated by lactobacillus, and the fourth group, the fourth type, what we call the community state type number 4, showed low to no lactobacillus present and was subsequently determined to be the least stable, fluctuating throughout the menstrual cycle. Furthermore, the absence of lactobacilli was associated with the increased risk for bacterial vaginosis, sexually transmitted infections, endometritis, pelvic inflammatory disease, and miscarriage, which has sparked significant interest in the importance of the vaginal microbiome. Type 1 was dominated by Lactobacillus crispatus and found to be the healthiest with the lowest pH, most resistant to dysbiosis, and most stable throughout the menstrual cycle. Community state type 2 is characterized by Lactobacillus gasseri dominance and also rarely associated with disease. Community state type 3 is Lactobacillus iners dominant, but due to the abundance of the L-lactic acid versus the D-lactic acid, it's less effective at inhibiting dysbiosis. And community state type 5 is predominantly Lactobacillus jensenii. It's less common, but still considered healthy. Up until that research, the distinction between community state types was less clear. We knew the vaginal microbiome fluctuates through the lifespan. What remains consistent is our understanding that a healthy vaginal environment contains predominantly Lactobacillus species. The number of Lactobacillus species in the vagina can fluctuate, and it's influenced by hormones and lifestyle factors. During estrogen decline, there's a corresponding drop in glycogen in the vagina, which feeds lactobacillus. How many of you have seen the work of Dr. Lisa Mosconi's MRI images of the brain post-menopause with the depleted glycogen stores in the brain? We're seeing that same glycogen depletion in the vagina too. If you joined our conversation yesterday with Microbiome Labs and Dr. Anna Kabeka, you may remember this graph depicting the blood hormone concentration in women. I think it's important to share because we're not just addressing postmenopausal hormone decline affecting the microbiome. We're seeing these changes as much as 10 years before a woman experiences menopause, when her hormone levels are starting to deplete her protective lactobacillus species. This is particularly important for our female patients that are conceiving later in life, when they are starting to see that dip in progesterone, estrogen, DHEA, and testosterone, and subsequently the glycogen and lactobacillus as well. Raise your hand if you treat perimenopausal and menopausal women or women struggling with infertility, because you'll want to pay particularly close attention to the next slides. This illustrates the comparison between the thick epithelium and the thick mucus layer in early reproductive years, which is associated with elevated estrogen, elevated glycogen, which support the lactobacillus population and subsequent decreased vaginal pH and lower microbial diversity. Because unlike the gut microbiome, where a high level of microbial diversity is favorable, the vaginal cavity favors a low microbial diversity. We can compare this to the postmenopausal illustration on the right of the thinner disrupted epithelium with a thin mucus layer, reduced estrogen, reduced glycogen and lactobacillus, and increasing pH and microbial diversity in the vagina. I hope by now you're asking yourself, what can I do to support the vaginal microbiome of my patients? We know that a healthy microbiome is associated with a high abundance of lactobacillus species, the low bacterial diversity in the vagina, the low vaginal pH, and dominant lactobacillus species, as we've seen before. So lactobacillus species are really critical to this conversation. Lower pathogen abundance can be created by three mechanisms using lactobacillus. The first being that lactobacillus produces lactic acid, which lowers the pH. It also produces bacteriocins and hydrogen peroxide, which modify the bacterial imbalance. Second, it inhibits the adherence of pathogens by producing biosurfactants that compete with attachment sites. Additionally, it coaggregates with the pathogens, allowing the pathogens to be swept away by the host body fluid. For women that have a cervix, that body fluid in the vagina is typically cervical mucus. But you can understand why postmenopausal women or those that have undergone surgical menopause and don't have a cervix producing mucus are more at risk for these pathogens hanging around longer. To summarize, the left side represents a healthy vaginal microbiome dominated by lactobacillus species, maintaining natural defenses. Whereas on the right, we see the disrupted lactobacillus population with increased risk, including bacterial and yeast infections. Now, what do you think of when you see this photo? I see a woman self-soothing herself by pulling her limbs close and making herself feel protected and supported. I chose this photo of a woman with body language that appears to be uncomfortable or even feeling anxious, fearful, maybe even shame, because we've all seen these patients. We recognize the complexity of the conditions we're about to discuss and the trauma associated with prolonged suffering related to any of these diagnoses. Throughout their lifetime, most women will be diagnosed with a condition associated with the vaginal microbiome. Let that sink in. Raise your hand if your healthcare provider has ever discussed the vaginal microbiome with you. Most women will be diagnosed with a condition that is associated with the vaginal microbiome, including bacterial vaginosis, urinary tract infections, yeast infections, endometriosis, pelvic inflammatory disease, female factor infertility, sexually transmitted infections, gynecologic cancers, toxic shock syndrome, and poor pregnancy outcomes such as premature birth, low birth weight, and miscarriage. When you see this list, you realize we are grossly miscalculating the number of women that likely suffer from vaginal bacterial imbalance at some point in their lives. But at a minimum, this data suggests it affects up to 50% of women. And over 50% of women affected will experience recurrent episodes within 12 months. Bacterial vaginosis is the most common vaginal condition in women ages 14 to 49, with a prevalence in the United States of over 20. UTIs are the most common outpatient infections, with a lifetime incidence of 50 to 60% in adult women. And 75% are likely to have at least one yeast infection during their lifetime, but nearly half have 2 or more episodes. And certainly we can all think of more patients than more than a few patients we've seen in clinical practice with far more than 2 episodes of vaginal yeast infections. In fact, if you have patients with recurrent antibiotic use, they may be concurrently managing a yeast infection every time they are prescribed an antibiotic or medication affecting their pH balance. If you're prescribing antibiotics, you've probably even had a patient or two that say, can you just please prescribe fluconazole now because I get a yeast infection every time I take an antibiotic. And we know that these infections aren't just inconvenient because they're one more thing we have to think about treating, but because they generally require that the woman has to figure out a plan for childcare, a plan for transportation, a plan to get to the office to do urinalysis, leave a urine sample, or do a vaginal collection. And these are the things that create huge inconveniences for a woman that's trying to manage a lot on her plate already between work and family and all the other responsibilities of life. So if the concept of the microbiome isn't new to you, you may be asking yourself, what is the role of the gut microbiome in this management? And it's an important question to ask. As a result of the close proximity, there is potential for microbes found in fecal matter to contaminate the vagina. Translocation of the species from the gut to the vaginal tissue creates increased microbial diversity that is poorly tolerated in the vaginal environment. The good news is that oral probiotics that promote healthy gut microbiomes will therefore affect the health of a vaginal microbiome. How do we know this? A higher incidence of bacterial vaginosis is found in women that carry bacteria in stool that is associated with bacterial vaginosis, such as Gardnerella. Oppositely, women with a healthy vaginal microbiome are found to have higher concentrations of L. crispidus in their stool. This means we don't have to wait for women to report vaginal symptoms before we address their gut and vaginal microbiome. Some of the mechanisms of this association include that gut probiotics containing lactic acid producing bacteria, like bacillus spores, can maintain the vaginal pH and obstruct the growth of pathogenic bacteria. By inhibiting the growth of unfriendly bacteria like E. coli, gut probiotics promote vaginal microbial health. Bacillus subtilis lowers inflammatory cytokines and promotes a favorable vaginal environment. Lastly, due to the close proximity of the urethra to the vagina, the vaginal microbiome can also play a role in the development of UTIs. So let's classify vaginal dysbiosis. Bacterial vaginosis, also known as BV, is associated with the loss of protective lactobacillus species like L. crispidus and L. jensenii from the vaginal microbiota and an increase in facultative and strict anaerobes, including Gardnerella and vaginalis and Provotellus species. Bacterial vaginosis is a dysbiosis of the vaginal microbiome that has been associated with a wide variety of adverse health outcomes, including premature birth, endometritis, and enhanced transmission of HIV and other sexually transmitted infections. Bacterial vaginosis is the most common cause of vaginal symptoms among women, affecting just under 30% of US women ages 14 to 49, based on NHANES data. And approximately 84% of the women that were found to have bacterial vaginosis reported no symptoms. Women who have not had intercourse can still be affected by bacterial vaginosis, as can pregnant women and women who have never been pregnant. The prevalence of bacterial vaginosis increases based on lifetime number of sexual partners, but also based on your partner's numbers of sexual partners throughout their lifetime. There are racial disparities among women that have higher rates of bacterial vaginosis, with increased African American and Mexican American populations affected. Perhaps one of the most devastating points that we'll address shortly is that conventional treatment for bacterial vaginosis results in a 50 to 80% recurrence rate. A brief quiz to see if you've been paying attention. What diagnosis have we discussed that affects an estimated 75% of women at some point in her lifetime? This number may be underreported by all of the women that seek at-home remedies or didn't know what they were experiencing. But an estimated 75% of women will have at least one episode of vaginal yeast infections in her lifetime. Vulvovaginal candidiasis is often caused by antibiotics that kill off the protective lactobacillus species and leaves the ecosystem vulnerable to overabundance of Candida species. And we know that the candidiasis can present differently for different patients. Sometimes it can present with vaginal discharge, for others, burning while urination, vaginal itching, pain during intercourse, or sometimes a rash or swelling. There's also data to suggest an association between dysbiosis of the urinary microbiome and disorders of the urinary tract, such as UTI, interstitial cystitis, also known as bladder pain syndrome, and urinary incontinence. Healthy states of a urinary tract is associated with increased lactobacillus. Are you seeing a trend? The urinary microbiome, affected by a variety of factors, is including diabetes, vaginal infections, medications, and hormones. In patients with UTIs, we see a higher pH in addition to bacteria like E. coli, Enterococcus, Staphylococcus, and Gardnerella. Certainly, I'm sure you can think of many patients, particularly your elderly patients, that may not present with typical signs and symptoms of a UTI. In fact, it's not uncommon for elderly patients to know altered mental status before they complain of pain with urination. However, common symptoms include dysuria, urgency, discoloration of urine, frequency, malodorous urine, and pelvic pain. And the reason we take a response to the urinary tract infection so seriously is that complications of a UTI may include recurrent infections as defined as 2 or more UTIs within 6 months, or 3 or more within a year. Permanent kidney damage from a kidney infection due to an untreated UTI, delivering a low birth weight or premature infant when a UTI occurs during pregnancy, and sepsis if the infection travels up the urinary tract to the kidneys. As we move our discussion to treatment options, I want you to be thinking about patients you've seen recently, including those with recurrent infections or antibiotic use. Like most clinicians, you're probably recalling every patient with recurrent infections that you've seen in the last 10 years. Because as empathic providers, we want to heal these patients, and their stories stay with us. These are the patients that desperately need you to show up with a better understanding of the root cause of their disease. I've included a comprehensive list of references at the end of these slides, which will be sent to you, but I encourage you to do a PubMed search on lactobacillus and any of the conditions disproportionately affecting women that we're talking about. So what patients should you be thinking about as we move forward? Perhaps they're patients with a history of vaginal related conditions like recurrent UTIs, yeast infections, bacterial vaginosis, a history of antibiotic use, patients trying to conceive, postmenopausal women, endometriosis, PCOS, postpartum, lichen sclerosis, interstitial cystitis, or bladder pain syndrome. What's significant about this list of conventional treatments of bacterial vaginosis and vulvovaginal candidiasis is not that the first line treatment of bacterial vaginosis of antibiotics like metronidazole or clindamycin have not changed or evolved in decades. But remember that women treated with these first line antibiotic therapies for bacterial vaginosis see up to an 80% recurrence rate, and we still haven't found a better option. Additionally, the first line treatment for vulvovaginal candidiasis generally remains an antifungal treatment, typically fluconazole. Which brings me to the point of our next tools in the toolbox. And I'd like to start with Astarte. Astarte is a unique blend of 4 lactobacillus strains that should sound familiar if we think back to our conversation around vaginal community state types. Astarte includes L. crispidus, L. jensenii, L. gasseri, and L. rhamnosus. And we'll review the research in just a moment, revealing how Astarte reduces the bacterial imbalance in the vagina and decreases digestive and vaginal complaints. But I want to point out that it's unique because of its resilience in aerobic and anaerobic environments and resistance to biosalts. So you're probably asking, how does Astarte work? Lactobacillus strains support vaginal health by producing lactic acid, which lower the pH. They produce hydrogen peroxide to modify bacterial imbalance and normalize the vaginal microbiota and increase abundance of common lactobacillus in the vagina. And this is where it gets exciting. Let's dive into the data. A double-blinded randomized control study assessed the effect of Astarte on patients diagnosed with bacterial vaginosis. The outcomes they measured were that they assessed included recovery rate, discharge, odor, and the AMSEL score. And for those of you unfamiliar with the AMSEL score, it requires at least 3 of 4 criteria to be present to diagnose bacterial vaginosis. It includes vaginal pH above 4.5, for which we often use pH strips in clinical practice, a thin homogeneous discharge, perhaps a positive whiff test revealing a fishy odor, or clue cells on a saline wet mount of a vaginal smear. Now, Lau's research found Astarte significantly increased the percentage of women without bacterial vaginosis to 100% when used in combination with the standard treatment. And Astarte induced a significant reduction in the AMSEL score symptoms. Furthermore, research found a significant reduction in discharge and odor. So in review, we found that Astarte strains lower the pH by making lactic acid, they modify bacteria balance by making the hydrogen peroxide, and they help normalize the vaginal microbiota. Moving on, the next randomized control study evaluated the efficacy of Astarte taken twice a day by pregnant women and measuring outcomes that included the presence of Candida species after intervention and vaginal discomfort. Astarte significantly reduced the percentage of women with the presence of Candida species by 50%. Astarte also led to this significant, almost 67% reduction in the number of women complaining about vaginal pruritus. And when we look further at the in vitro studies produced by Dr. Konrad Domig, in addition to the impressive response of Gardnerella vaginalis to Astarte, we can see even less common Candida species, often the culprit of some of the most persistent infections plaguing your most challenging patients, were responsive to Astarte as well. So although we didn't have time to review the data surrounding placental insufficiency or preeclampsia, Astarte strains improve the microbiome and are found to increase lactobacillus colonizations, decrease vaginal pH by making lactic acid, significantly reduce vaginal itching, modify bacterial balance by making hydrogen peroxide, and decrease the incidence of pathogens. Here's a brief overview of the studies we just discussed. If you're interested in reading more about them, they'll be in the slide deck that you received today. Next, I'd like to review Lactobacillus acidophilus, also known as LA5. Eileen Hilton and her team completed a crossover 2-arm study assessing whether LA5 prevented vulvovaginal candida infections. What I love about the outcomes measured is that in addition to looking at candida overgrowth, they also evaluated infection recurrence. And what they found was significant. LA5 induced a significant 85% reduction in the number of infections and a 74% reduction in the number of candida colonizations in the following 6-month period. Research published in 2023 on a triple-blinded randomized control study compared the effects of LA5 and fluconazole on vulvovaginal candidiasis. Outcomes measured candida overgrowth, itching, discharge, burning, and dysuria. You'll be interested to know that LA5 showed no significant difference compared to fluconazole to treat vulvovaginal candidiasis. Both interventions resulted in a complete reduction in the percentage of women with candida species. Additionally, LA5 reduced the percentage of women experiencing discharge by 30% and burning by 60%. Furthermore, LA5 was found to improve itching by 58% and dysuria by 57%. In summary, LA5 strains improve markers of vaginal health, as well as reducing vaginal discomfort and supporting the reduction of yeast overgrowth, discharge, burning, itching, and dysuria. Again, here's a brief summary of the data we talked about. If you're reviewing these slides and you'd like to look up the studies, I invite you to read more. So we've touched on vaginal dysbiosis being related to fertility and pregnancy outcomes, but you're probably asking yourself, how is the female microbiome related to pregnancy and fetal outcomes? Research on maternal gut dysbiosis during gestation has been associated with gestational diabetes, asthma, eczema, celiac disease, type 1 diabetes, and obesity. Furthermore, we perceive this relationship with dysbiosis to be modified by increased inflammatory cytokines and decreased Treg cells, resulting in inappropriate immune response in the offspring. Now, in 2006, as a graduate student at the University of Michigan, I was asked by my esteemed professor of epidemiology and the co-chair of a working group for the U.S. Surgeons General Conference on Preterm Birth, Dr. Dawn Misra, to assist with compiling a meta-analysis on preterm birth for the Institute of Medicine. We were looking to create a conceptual framework to inform our understanding of adverse birth outcomes affecting health equity. This was particularly meaningful to me growing up in Detroit, a city with a population with significant disparities in health outcomes. At the time, we did not have the growing body of research that exists today linking the vaginal microbiome and preterm birth. However, today it is widely embraced as a risk factor for miscarriage, as the data has revealed that preterm birth is more likely among women who have had an abnormal vaginal microbiome. Furthermore, Gardnerella vaginalis and ureaplasma can increase the risk of pregnancy loss. Absence of lactobacillus in the vaginal tissue during first trimester of pregnancy may be associated with increased risk of pregnancy loss in the second trimester, furthering our understanding that miscarriage and vaginal dysbiosis can be linked. So as we transition our conversation to new ingredients associated with improving the microbiome, I want you to be thinking about your pregnant patients or those that are postpartum and maybe breastfeeding or pumping breast milk. And next, I'd like to talk about lactobacillus strain LGG. There's a good chance you've read about the next ingredient because it's the world's most documented probiotic strain with more than 1,900 scientific publications and documented in more than 250 clinical studies. So LGG is a L. rhamnosus strain that was isolated from the intestine of a healthy human. It supports immune and gut health and has been used around the world since 1990. In a clinical study published in Nutrients, which supplemented pregnant women from gestational week 33 until 4 weeks postpartum, LGG was recovered from 95% of the women supplemented. Now, this one's a little bit hard to get your head around, but there's 3 clinical studies that investigated the effect of LGG pre and postnatal seeding on red and scaly skin of children randomized in a double-blind placebo trial. What we found was that half of the women continued to take LGG and half of the infants were given LGG for 6 months. And they found that significantly fewer children had red and scaly skin, independent of whether they were given LGG directly or via the mom. 50% less than the placebo at age 2 had red and scaly skin, fewer than, or 43% fewer than the placebo at age 4, and 35% fewer than the placebo at age 7. Istulose is a unique strain of Bifidobacterium longum, and it's derived from the intestine of a healthy infant. Highly specialized in human milk oligosaccharide utilization, Istulose modulates the intestinal barrier and regulates immune cells to protect the infant intestinal tract and support the seeding of a healthy infant. Again, the data shows that when a mom took Istulose 2 to 4 weeks before delivery and continued for 28 days postnatally, followed by a 2-week period without supplementation, they found that in the infant seeding group, when the mother did not take probiotics before and only the infants were given Istulose for 28 days, followed by a 2-week period of no supplementation, that the infants were predominantly breastfed in both groups through the end of the study, day 42. And both the maternal and infant supplemented group resulted in the recovery of the probiotics in the infant fecal samples. We perceive the mechanism of action of Istulose to be that the metabolites produced by Istulose act in 2 ways. They affect immune system development by feeding butyrate producers, which is essential in regulating immune responses. Additionally, the metabolites protect the gut barrier, as butyrate provides an energy source for the intestinal epithelial cells. Butyrate and lactic acid support intestinal barrier function and strength. In summary, Istulose is a unique probiotic strain that can thrive in the female reproductive tract and support both maternal and infant health. It is naturally occurring, compatible with the infant gut. It is highly effective at supporting the immune system and gut barrier. It is stable and durable and tolerant to stomach acid. And I hope that we all walk away from today's conversation with an understanding that there are specific targeting and clinically studied probiotics that may be an effective tool to support these women in their journey to optimize health. The vaginal microbiome is critical to the specific health challenges that women may face, and we have successful clinical interventions that depend on appropriate identification of dysbiosis risk factors that affect the vaginal microbiome. So I welcome you all to join me as providers in helping recognize the vaginal microbiome concerns that your patient has. I've included for you a list of some of the citations that were discussed during today's talk, and I thank you again for joining, and I welcome any questions.
Thank you so much, Maureen. What a wonderful presentation. And we want to say thank you to everyone who has joined us today. So questions are pouring in. Sandra asks, how long should women take the lactobacillus for BV and reoccurring infections?
So some of this will depend on your patient. Certainly for patients that have recurrent symptoms, the lactobacillus is safe for them to stay on continuously. What we know is that although we do see seeding where these colonize in the female microbiome, that it does have reoccurring benefits to stay on these these protocols for an extended period of time. So I would say for an acute patient, you may only need them for a 4-week period. But if you have patients that are having reoccurring episodes, it's important to consider what are their risk factors. Do they have a partner where every time they're exposed to their partner, they're having a recurrence of infections? What are their triggers? If that's the case, then you may need to tailor their introduction of the lactobacillus more frequently.
Excellent, thank you. Minnie is asking, can postmenopausal women take lactobacillus as a prophylactic?
Absolutely. We definitely intend for women to have protection before they have infection. And so being able to use a protective strain like the lactobacillus strains in Astarte, for example, provide significant protection against those variations that can create the dysbiosis.
Excellent. And a question about the supplements. Are they taken orally or vaginally?
So Microbiome Labs was provided a clearance to provide oral probiotics. It's not to say that providers couldn't give individual instructions to patients if they wanted to use them differently, but the probiotics that we're talking about are meant to be taken orally.
Excellent. Jenna asks, a client of theirs was told by a gynecologist that BV can take 1 year to heal. Do you have any thoughts on that?
Certainly, when you think about that vaginal microbiome list that we talked about at the beginning with factors including hormonal changes and stress, diet, and environmental factors, none of those things are likely to change immediately, maybe aside from the exposure to the fabric someone's wearing for their underwear. So when we're talking about dietary changes, sometimes there's internal gut microbiome issues that you're dealing with simultaneously. And for patients with, gut dysbiosis, sometimes that is taking months, up to a year to heal. When it comes to the vaginal dysbiosis tissue, because of the factors and the translocation of the fecal matter that can affect the vaginal tissue, or the gut dysbiosis that can affect the vaginal dysbiosis, we certainly understand that there's that cross play and connection between the two microbiomes. With that said, for menstruating women that have a menstrual cycle every month, the blood flow acts like a natural flush of their microbial bacteria in their vaginal tissue. So when they're emptying out that and flushing that bacteria in the vagina each month, they sort of have a chance to reset what that environment looks like. And so if a patient had, an irregular symptoms, the last month, and then they have a menses, that's a great time for them to introduce the lactobacillus and repopulate the healthy protective bacteria.
Excellent. Pam is asking, will Astarte help perimenopausal thinning of the vaginal walls?
So although we don't have any reason to think that it will replace the role of our important hormones like estrogen and progesterone, DHEA, and testosterone, we do know that it's one of the reasons why that perimenopausal period can be so traumatic and symptomatic for women is that decrease of hormone levels reduces the glycogen, which reduces the lactobacillus. And so although it wouldn't replace the thick mucus layer maybe entirely on its own, it will hopefully at least protect against pathogen invasion and at least prevent the overgrowth of abundance of invasive species that are causing symptoms.
Excellent. And Pam just tapped in to say post-menopausal, not thinning, not
Right.
pre-menopausal. Just
yeah,
any
the same is true.
Okay, perfect. Excellent. Olivia is asking, how long do you recommend patients take probiotics to support vaginal dysbiosis?
So this question again will depend on your patient. And if you're starting off with some internal gut dysbiosis issues that you're managing concurrently, as is the case for most of the patients that I've seen, when it comes to vaginal dysbiosis in a patient that's doing everything right to support their gut microbiome already, you may be treating, each patient uniquely depending on how persistent their symptoms are. It is not unreasonable for a patient that is trying to prevent vaginal dysbiosis, during preconception to take those probiotics the entire time that they're preparing to conceive, or for a patient that is sexually active and trying to prevent that rebound of a response to their partner every time they have intercourse, to be protective against an infection or a urinary tract infection every time that they're sexually active. So really this will be tailored to your patient's lifestyle and what their concerns are and the frequency of their concerns.
Excellent. Perfect. Another question that we have is, are there any good pre or probiotics which are more plant-based for certain patients for the healthy vaginal wall? Any recommendations?
So if I hear your question again, are there any pre and postbiotics can you repeat the question?
So of course, yeah. Are there any pre or postbiotics that are more plant-based that you would recommend?
Certainly. So, much of what we were talking about today, we're really trying to identify very highly specialized species that serve a really specific role in the vaginal microbiome specifically. However, this doesn't take away all of our information that we know about pre and probiotics that we can get from our diet. So much of our pre and probiotics that we can get that are plant-based, include kimchi or sauerkraut or fermented foods that we can incorporate. They give us an overall, support from a dietary perspective for pre and probiotics, but they aren't necessarily tailoring the specialized treatment that we want when we're trying to target specific functions. So when I think back to my clinical practice, when patients came in and they were, maybe dealing with diarrhea or constipation or dysbiosis in the past, we may have recommended general probiotics for their well-being. This conversation has really changed, and specifically our understanding of the community state types, are that there's specific strains of the lactobacillus that are more protective than just eating kimchi alone. And so we can use the pre and probiotics from our plant sources to support our overall microbiome, but really having these tools of the specific strains are what empower us to make a real clinically significant difference.
Excellent. Sandra is asking, are there any concerns for a client who is lactose intolerant?
No, there's no contraindications for patients that are lactose intolerant for these strains.
Excellent, excellent. Well, this has been such a lovely conversation. I really appreciate your time, Maureen, and everyone who joined us today. This webinar is being recorded and will also be available at fullscript.com/webinars within a couple days. We'll also be sending a follow-up email that will include a special offer for everyone who attended today. So please check out your email inbox for that. And I just want to say thanks so much to everyone. And any final thoughts, Maureen? Not to put you on the spot a little bit, but just sort of wrapping us up here and sending us off.
No, at Microbiome Labs, we welcome communication. So if you have further questions, please feel free to reach out to microbiomelabs.com or your rep for further information.
Excellent. Thanks so much, everyone, and have a great afternoon.